Welcome to another Unfiltered production. Today you have Sherry Teague and Cindy Krafft, and we have a hot button issue that has been a point of discussion between the two of us for a little while. But Cindy, I wanted to kind of start us off with using, historically we've always championed using the OASIS document as a care planning tool. What do you mean by that?
Well, I want to kind of start with what we don't mean. We don't mean that the OASIS stands alone as some sort of clinical document, that there's a one-to-one relationship between what we find on the OASIS responses and a care plan. I've seen agencies try to do that, particularly about utilization. If we get certain points in certain areas, that's how many therapy visits we should have or how many nursing visits. That's not what we're talking about. What we've stressed is a degree of harmony, especially around outcome-related issues. Because if I'm really trying to get positive patient outcomes, yes, the OASIS responses need to be correct. And we need to make sure the start and the end of an episode of care have correct responses. But do we see intentionality around those outcomes in the middle? And my favorite example, Sherry, is always going to be item 1860, because we look at it and we say, well, it's ambulation. So if there's an ambulation problem, we should get physical therapy. Okay, yes, but then we see physical therapy completely focused on distance, device, and level of assistance, and not that layer of what 1860 really gets to is, do you need continuous involvement of another person, which is 3 when you're up and walking, versus a 2 where it's intermittent. So no one's suggesting that we completely pivot therapy documentation and make it about continuous versus intermittent, but the disconnect doesn't make sense. So I think sometimes we're hyper vigilant about the measurement at the beginning and the measurement at the end, and then kind of let the middle be fluid and nondescript. I think if we're going to collect this data, integrating it into care planning makes the most sense.
Is that also going to be true in OASIS E though?
Well, this kind of triggered the trigger for what ultimately led to this unfiltered discussion was I'm starting to hear, OASIS E has these new questions in it. And okay, so now we're going to have to take these questions and build them into care plans. And a concern that, well, several of these questions, okay, now we have things about transportation. Has an issue with transportation impacted your ability to get medical appointments or access to food? And these social determinant of health related questions, which, Sherry, you and I can agree, they're a great addition to OASIS. I mean, who better
Absolutely.
than home care to identify this? But hearing this kind of woe is me, this is going to have to be put into a care plan now, kind of, first of all, gave me pause. It's like, really, we weren't finding out about their access to food before OASIS E? I mean, that seems like a rather important conversation, regardless of a tool, to make sure your patient is able to get their food and their medicine and what they need to survive, let alone thrive in a care plan. But putting that aside, it was like, okay, yeah, I can see where some of these could build those triggers into care planning, potentially interventions and goals, that kind of thing. But then it struck me that that tone is what's going to have to be put on the admitting clinician. And we know, despite the waiver situation, historically, the majority of admissions still end up being the nurse, followed then by PT. And now OT's joining that, but they got a while to catch up numbers wise. But I'm thinking, wait a minute. So why are we going to take these identified issues and automatically put them on the plate of the admitting clinician, who we already know is trying to get all kinds of other things done to get this episode of care started, and the staffing situation we're in and all the other pressures going on? Why do we want to add more burden as opposed to looking at what is our full interdisciplinary team? And we know it's nursing, PT, OT, speech, aid. Yeah, but there's a sixth one. And when we're talking about issues around transportation and food insecurities and all of that, that screams social worker to be. That does not scream one more thing for the admitting clinician to have on a list that's going to end up on a very long, as we've seen, Sherry, very, very long at times, care plan that doesn't necessarily get completely executed because we put everything on the kitchen sink on it. And so who's focusing on what? But why would those things automatically default to a nurse or the PT or the OT? Why would we not readily bring in the social work? So when I talk to you about this, Sherry, because I came at it from the OASIS E world, my brain always gets stuck in. But what are your thoughts about OT utilization? If we took E out of it, what does social worker utilization look like today from your perspective?
Oh, it's very rarely used. And in fact, if you look at the cost report data, it's the least used service in the home, and it should be one of the middle to high used services. I mean, how many notes do we read that we hear about the squalor that people are living in, the filth, the bed bugs and animals and strange relatives that live in the house and missing medications and all of these wonderful, glorious things that we find in home health. Please don't let us discourage you from practicing home health. It's a very rewarding place to practice. And oftentimes the clinicians, when we read social media posts, the clinicians are just frustrated because a wound won't heal. B, they don't know if their patient has access to their medications, much less is able to take their medications and or their nutrition. So, I mean, I don't know why. I cannot figure out why we don't access that sixth individual that is a skilled service that's paid by Medicare and counts towards covering a LUPA. Oh my God, what? Yeah, it can help if you have a couple social worker visits, you can help avoid LUPAs using your social workers and helping your folks get into a better situation. So I don't know, Cindy, I'm clueless. I don't know why agencies don't take advantage of that.
Well, and unfortunately, as many records as we've reviewed, when they are included, more often than not, they seem to be late in an episode of care. It's almost like you can see the trajectory on that narrative at the beginning, issues like you just described are identified. They're identified then throughout the course of care, but then, oh my gosh, we're nearing discharge. Now what are we going to do? The patient lives alone. The patient was living alone when you admitted them. The
Mhm.
patient was having these challenges early on. Why are we waiting so late? And then it's a single visit with apparently brochures left. That's very often written materials are left. And then you might see in a communication area a subsequent phone call, but it's like, really? That's the best we could do in the home where we have a ringside seat to all kinds of things. And I have to wonder, and it just struck me in the head when you were talking now, Sherry, don't you think some of this contributes to the burnout of nurses in home care when I'm trying to shoulder all of these things? And maybe some of it is really not what they need to be dealing with, that I need more robust social worker support of this family so the nurse isn't feeling always responsible for bed bugs, family dynamics, missing medications. Yeah, we all have a role to play, as does therapy in that. But if we're seeing this, why would we not be calling for reinforcement?
Exactly. I'll never forget. I was at a function in Ocala, Florida, and I had an opportunity. I was sitting at a table, and it was one of those brainstorming tables for elder services, senior services in the Marion County area. And at my table happened to be a supervisor from Adult Protective Services in Florida. And having owned an agency, I asked her the question. We're so hesitant to call Adult Protective Services because it feels like we're judging the family. It feels like we're the judge and jury and we're making a bad call. And she said, and one of the things that she said to me really stuck with me is, we wish you would call us first. And I said, well, doesn't that get people in trouble? And she said, no, it makes us aware that there's potentially issues and it speeds up assistance on the back end. And that just struck me. And I thought to myself, when I was sitting there at the table, I thought, well, we have a social worker. Let's do all we can as an agency. And then if necessary, we're not able to access the care or the support in the community, then we get APS involved. And then that opens up a whole many more doors to a family than what we can as an agency. So it was a no-brainer back then. And those of you that have not been doing home health very long, we used to actually get paid for dietitian and for respiratory therapists in the home. I know, pick yourself up off the floor. But part of the reason why we don't get paid for those anymore is because we did not use them. I'm fearful, Cindy, and maybe you are too, that if we don't begin to use our full breadth of available resources for these patients, that we may lose the ability to use a service like MSW in the future.
Well, you're absolutely right. I mean, Medicare trusts us implicitly. I know people also flinch at that. They do. What the OASIS responses say, what our care plans say, they're trusting us to do what's best for these individuals. And if we're saying we don't need social work other than once in a blue moon, then they believe us that that must be patients don't need it. So when we talk about those social determinants of health and how our patients are challenged, their response is pretty Okay, that can't be that much of a problem because you're not really utilizing the service very much. So this is not meant to be any sort of criticism of social work. It's meant to be, can we just think about this a little bit differently? And if OASIS E helps with those questions to revisit this topic, I'm all for that. But let's look at it and say, are we utilizing everything at our disposal? Are we making sure that we're setting this individual up for success? Are some of these patients that we then dub return, repeat offenders and frequent flyers, is it really a social worker issue that really could make or break this situation much more successfully? And when we're thinking about value-based purchasing, the overriding reason they're expanding it is because they were able to demonstrate cost savings keeping people out of nursing homes and out of the hospital. And a social worker can be a huge part of that. So Sherry, thank you for indulging my rant this morning. It just really hit me again. It's like, why are we not? We're not saying, we're going to have a billion zillion social work visits, but it's really worth taking a look at this and saying, how are we maximizing the team and not overloading one part over the other? But the bottom line is, what are we doing to make sure our patients maintain their safety and their quality of life in the home?
Before we forget, this one was titled OASIS E and the MSW. However, you can begin that process now because it is a paid service now, even in OASIS D, when you see those difficult challenges in the house. So thanks, Cindy, and hopefully, we'll do another one really soon. And if you have any suggestions for topics that we should cover, please let us know. Have a great day. Be safe.